Patients receiving home care services are often housebound, making focused on-site wound assessments critical to improving healing outcomes. While wounds are assessed and treated in a standardized practice by wound presentation in response to treatment care options, there's little consistency in addressing contributing factors that may adversely affect healing in these patients. This translates to inconsistent care coordination, which can delay ancillary care services or have referrals missed entirely, jeopardizing patient outcomes. The project's PICO question is in adult home care patients that are admitted to home care services with a nutrition risk score of moderate to high risk, how does the incorporation of a triage care coordination algorithm impact care access to resources over 4 weeks compared to patients not receiving a triage care coordination algorithm for resource care access? The project's design, the Wound Care Champion RNs performed admissions to prospective patients and implemented a triage care coordination algorithm workflow. All home care patient referrals were screened for those meeting patient project criteria and scheduling with the Wound Care Champion RNs. Also, to perform assessments in patient project participants and non-project patients, to determine home care agency response and receptiveness to workflow change. And lastly, addressing patient satisfaction and care coordination and timeliness. The results for non-patient project participants, 3 out of 20 had social workers within 4 weeks, 1 out of 20 had a dietitian order, and 19 out of 20 had seen a provider by 4 weeks. 13 out of 20 had labs done, and this was in a 4-week time period, only 4 of which were project-specific labs. Patient project participants, 50% had social workers within 2 weeks, with 50% non-provider response for orders. 100% had seen their providers within 2 weeks, 75% labs within 2 weeks, and 50% had project-specific labs. Project threats, barriers, and tactics used to overcome and facilitate. Case management RN enrollment to the QI project was slow and conservative. A pre-invitational email sent prior to formal clinical project introduction email was also available. Follow-up email was provided 3 business days after project introduction. Individual calls were made and needed as checking in for Q&A. Patient project participant enrollment was low. Patient project participant age criteria was increased to 18 to 85. Check-ins were also made with the intake referral RN. Staffing was challenging. Non-scheduled days were worked by project lead to increase the number of prospective admission screenings, and Wound Care Champion RNs volunteered were able to pick up